to dinner. Just kind of a regular old weekend. All right, Louisville, Kentucky, Saskatchewan, UK, Florida, Huddersfield, UK, Slovakia. Very cool. North Jersey, St. Louis, Newcastle, Pennsylvania, Gibraltar, Delaware, Edinburgh, Scotland, Nova Scotia, Minnesota, Vermont, Florida, Singapore. Looks like people did gardening over the weekend. Oh, yep, I got some leaves removed. I have so many leaves. I tried myself. It wasn't happening, so I had to hire someone. Kentucky, Croatia, Canada, UK, Grand Rapids, Virginia, Alberta, Wisconsin, Iowa, congrats, 30th wedding anniversary, very cool. New Brunswick, Malta, Des Moines, Springfield, Missouri, West Vancouver. For those of you just joining us, welcome. We'll get started in just a minute. New York, Indiana, Iceland, Malta. We're just sharing where we're from. Oh, who ordered t-shirts? I got my t-shirt on. I'm wearing it every day this month. T-shirts are only on sale in May, so we only have half the month left to order. We do ship internationally, so you can order and get yours sent internationally. Who has ordered their shirt? And if you've ordered it, take a picture and tag us on social media. I don't know if everyone saw on our social media over the weekend, there was a high school that bought some shirts, which was super cool. I love my shirt. I was sporting my shirt in a selfie. So let me know who's got their shirt, who's ready to be a twin with me. Even though my 12-year-old niece tells me it's not cool to be twins and wear same clothes, but I think it's cool. So we can all wear our same shirt. Hollywood, Florida, New Mexico, England. Jacksonville. Oh, it looks like some people did some gardening and now it's getting cold, so the gardening might die. That would be sad. Yeah, I'm waiting because I do have a habit of planting too soon and then it doesn't go work. It does not work. Minerva got your shirt. Okay, take a picture, post it on social media, let us see it. Cape Town, South Africa, UK, Ireland, Flagstaff, Arizona, Pennsylvania, Cincinnati, Ohio, Puerto Rico, Saskatchewan, Dubai, New York City, Scotland, Ireland, Texas, North Carolina, Sweden. Rachel ordered her shirt today. I'm going to put the link for ordering shirts into the Q&A just in case you have not done yours yet. Order it today. Dr. Lucas ordered the shirt. Awesome. Can't wait. It's all right if you don't use social media. If you're interested in us posting your picture, you can always email it to us and we'll post it on our social media. But not everyone's comfortable with that, and that's okay. Albania, California, Louisiana. For those of you asking how to get the shirt, I just put the link into the Q&A so you can click there. We'll also put it in the email we send out tomorrow. Wisconsin, South Africa, Wales, Bermuda. Renee, you can't see me in my shirt. That's okay. If you go to Mindspring's Facebook or Instagram page, you can see a pic of me in the shirt. Check it out there. Calgary, London, Nigeria, Washington, D.C. Wendy ordered the shirt. Sherry ordered the shirt. All right, we got lots of shirts ordered. Melissa, can't wear black because of your white dog. I can't wear white because of my black dog. I feel your pain. I feel it. All right, enough of my chatting. Let's get started. So today we're going to be talking about understanding eating disorders. And this is brought to you by Mindspring Mental Health Alliance. Special thanks to the United Way of Central Iowa for partnering with Mindspring and sponsoring today's webinar. So like always, everyone's mics are muted, cameras are off, Q&A feature is on. So if you have questions today, hop on into that Q&A, send them over to me. I will check questions as we go through. If you ask a question that I know I will answer through a future slide, I'm going to hold off until we get there. And then I'm going to save a little bit of time at the end for questions and answers. So we're going to end in about 50 minutes. I will answer questions as long as time allows. Also at the end are going to be 2 surveys. One is a satisfaction survey. My goal is for everyone to leave here feeling like they learned something, and that survey lets me know if we reach that goal. The other is a demographic survey. So I'm going to collect a little bit of information from you for our funders to continue to bring these to you free of charge. Both of them are super short, they're anonymous and confidential, and it really helps us out if you'll stick around at the end and complete both surveys. For anyone that is new, my name is Jamie. I am a licensed master level social worker, also known as a licensed clinical social worker. When I'm not here doing these webinars with all of you, I am a therapist. I work with both adults and adolescents. Prior to that, I worked heavily in child welfare, working with kids and teens that had experienced some abuse or neglect, many of them being part of the foster care and adoption system. Now let's go over our frequently asked questions. So this is being recorded, and everyone who registered for today's webinar will receive an email tomorrow with a link to the recording in it. No slides will be sent out. Certificates of attendance are sent to everyone who attends the live webinar presentation and completes the surveys at the end of the session. So those 2 surveys that I just told you about, both of those need to be completed to get your certificate of attendance. Certificates are not available for anyone who's only watching the recorded version of the webinar later on. And CEUs are not provided for community education webinars. Closed captioning is available. Captions can be turned on or off by clicking the CC button at the bottom of your screen. All right, so what are we going to go over today? We're going to talk about what an eating disorder is, the various signs and preventative factors for each of them. We'll talk about the different types of eating disorders, and then we will end with some practical steps if you or someone you care about are experiencing signs and symptoms of an eating disorder. So let's just hop right into it. What is an eating disorder? So it involves extreme disturbances in eating behaviors and can include things like following rigid diets, binging on food in secret, throwing up after meals, or obsessively counting calories. So people with eating disorders use food to deal with uncomfortable or painful emotions. Restricting food is used to have a sense of feeling like they're in control. Overeating temporarily can soothe sadness, anger, or loneliness. And purging is used to combat feelings of helplessness or self-loathing. So distorted, self-critical attitudes about weight, food, and body image are all involved in an eating disorder. It's these negative thoughts and feelings that fuel the damaging behaviors. And over time, people with an eating disorder lose the ability to see themselves objectively, and obsessions over food and weight come to dominate everything else in their lives. So the road to recovery begins by identifying the underlying issue that's driving the eating disorder and finding healthier ways to cope with emotional pain. So let's talk about some myths that come along with eating disorders. So first myth is that you have to be underweight to have an eating disorder. And that's just not true. People with eating disorders come in all shapes and sizes, and many individuals with eating disorders are of average weight, or they may even be overweight. The next myth is that only teenage girls and young women are affected by eating disorders. And fact is that while eating disorders are most common in young women in their teens and early 20s, it can be found in men and women of all ages, from children to older adults. The next myth is people with eating disorders are vain. And this really isn't about vanity. It's not what drives people with an eating disorder to follow extreme diets and obsess over their bodies, but rather an attempt to deal with uncomfortable feelings. And the last myth, eating disorders aren't really that dangerous. Fact is eating disorders are a serious condition that cause both physical and emotional damage. All eating disorders can lead to irreversible and even life-threatening health problems, such as heart disease, bone loss, stunted growth, infertility, and kidney damage. So let's go over some of the statistics. Eating disorders affect at least 9% of people worldwide. 9% of the US, or 28.8 million, will have an eating disorder during their lifetime. About 26% of people with eating disorders will attempt suicide. And then the economic cost of eating disorders is $64.7 billion every single year. Less than 6% of people with an eating disorder are medically diagnosed as underweight. So that's an important part, right? We are going back to that myth of talking about people with eating disorders have to be underweight, and it's just not true. Only 6% are. Eating disorders are amongst the deadliest mental illnesses, second only to an opioid overdose. And 10,200 deaths each year are the direct result of an eating disorder. So it's one death every 52 minutes. So, like we talked about in those myths and facts, women, females, so girls, teens, adult women struggle with eating disorders more frequently than men do, but men do face eating disorders. Unfortunately, it's widely believed that men rarely develop eating disorders, and it's just not true. And this belief can lead to a later diagnosis from medical professionals and can increase the risk of death associated with these disorders for men. Recent research from the Department of Psychology at York University in the UK has found that women are more likely than men to experience brain activity relating to negative body perception. So this may be one of the reasons or triggers for the disparity in the amount of eating disorders. So what we see on our screen now is 95% of people with anorexia nervosa are women, 80% with bulimia nervosa are women, and then interestingly enough, binge eating is about 50-50 men and women. Then let's talk about how eating disorders kind of go along with other mental illnesses, co-occurring mental illnesses. So people with eating disorders are at an increased risk for developing or being diagnosed with a mental illness. Depression tops the list with 70% lifetime prevalence in people with an eating disorder. So 70% of people with an eating disorder also have depression or are diagnosed with it. Anxiety is right behind at 63.5%. In addition, people with an eating disorder experience heightened anxiety around food and weight. So this can increase their likelihood of social anxiety disorder. So that's 20%, or OCD, 41%. Panic disorder at 11%, or trauma, and that's, or PTSD, post-traumatic stress disorder, at 13%. So research really clearly indicates that co-occurring depression or anxiety can then act as a barrier to someone receiving the expected amount of benefit from eating disorder treatment. So having that additional diagnosis can make it difficult, so that depression, anxiety, or other co-occurring mental illness needs to be treated as well. Now, what are the risk factors that come along with an eating disorder? So presence of these factors predicts higher risk, but does not guarantee the development of an eating disorder. So we need to remember that, right? Risk factor just increases the likelihood, but it does not guarantee it. So having mental illness like anxiety, depression, experiencing trauma, especially during childhood, like sexual abuse, having low self-esteem, experiencing social stressors like peer pressure, bullying. So all of those things can increase our risk of developing an eating disorder. So risk factors related to eating disorders, and then also about body image, may be tied to the development of eating disorders. So this can include weight-related teasing, and critical comments about weight. So maybe someone has experienced, maybe they're experiencing some depression. They've also experienced some negative comments about their body and their weight. This can increase the risk of an eating disorder. Also having a fixation on having a thin body, or experiencing childhood feeding, eating, or gastrointestinal problems, all are risk factors. Some studies have been done on twins, and these studies have isolated the role of genetics, and it's confirmed that approximately 40 to 60% of the risk of anorexia nervosa, bulimia nervosa, and binge eating disorder arises from a genetic influence. So we're not saying that there is a specific eating disorder gene, or even that our genes in general cause eating disorders, but some individuals may inherit a trait that is associated with the development of an eating disorder, things like anxiety, fear, perfectionism, moodiness. And these aspects of temperament have also been linked to a number of other disorders as well. The exposure to media, peers, parental messages can all contribute to whether a person idealizes thinness and engages in social comparison. So these two factors, that idealization and the social comparison, can potentially lead to poor body image and various forms of eating disorders. And eating disorders are likely the result of a kind of complicated play of all of these factors. Even when a precipitating factor, a traumatic event, that abuse as a child maybe, can be identified, there's always a combination of other contributing factors. For example, a person who is genetically susceptible to an eating disorder may be more sensitive to weight-related teasing and having a heightened reaction to it, like dieting that snowballs into an eating disorder. So long story short, it's not just one thing that puts us at risk or causes an eating disorder, but as a combination. Now, eating disorders are not entirely about food, but rather a way to kind of control the specific aspect in an individual's life. So a person may feel out of control, or they might feel powerless after experiencing a traumatic event. And then as a result, they use restricting or binging behaviors to control that aspect of their life in order to hide any kind of unpleasant feelings. And studies have shown that individuals who have experienced trauma are more likely to engage in eating disorders than people who have not. Now, we want to take into consideration adults, parents, guardians, with the important adults in children's lives. Right? Adults often lead by example, and unfortunately, they can forget how their actions and their words will impact children. When it involves body image and eating behavior, this can be especially relevant. Now, while many factors contribute to the appearance and development of an eating disorder, a mother or the maternal figure in a child's life, their attitude regarding body image does significantly influence how children view themselves. Studies show that mom or that female figure's concern about weight are actually the third leading cause of body image problems in adolescence. So casually discussing diet plans or describing a desire to lose weight when you are with teens or children can negatively influence their own image of their body. All right, before we move on to talking about signs and then the preventative factors, let me just check a few questions. So someone asked, is it common for therapists to check for eating disorders when treating clients for depression and anxiety. So every therapist does it differently, but most of the time you're going to be answering some preliminary questions before starting to work with a therapist. And one of those often is about eating, right? So if the person has any concerns about their eating, what their eating style is, amongst other things, right? We ask about sleeping and physical activity and those kinds of things, but there often are those questions. And then, a therapist will make note kind of to themselves, right? If they're starting to notice a big change in the client's weight, big shifts, but like we talked about in those myths, right? Someone with an eating disorder doesn't always have to be underweight, and they may not be overweight either. So it's not always super identifiable. And so it is looking for that and asking the client ways that they cope with big feelings, right? Eating disorders, like we talked about, are based in some of those traumas and a need for control. And so oftentimes clients will share that they cope with difficult feelings through food, whether it's eating or not eating it. And so, kind of related to that question is, could co-occurring disorders kind of hide or mask eating disorders? And it is possible, right? For a long time, what we looked for kind of stereotypically was being so underweight, but it's not necessarily true. So, like I said, a lot of it is about finding out if someone is using food as a way to try to cope with the symptoms of their other disorders. So if someone asked, how do we tell the difference between someone being kind of a picky eater and having an eating disorder? And that's really going to be about the diagnostic criteria. And we'll talk about that in a future slide. But figuring out, what the diagnostic criteria is will help you with that determination, but also finding out what their intention is. Being a picky eater because they just don't like certain foods is different than not eating because of how they feel about their body. All right, so let's talk about signs and preventative factors. So, first, we'll talk about the emotional and behavioral signs. So, behaviors and attitudes that indicate that weight loss, dieting, and control of food are becoming a primary concern. So, there's a lot of preoccupation with weight, food, calories, carbs, fat grams, and just dieting in general. May start to notice that the person is limiting the foods that they're willing to eat. And this is progressively becoming more and more extreme. This could include any kind of new practices with food or fad diets, including cutting out entire food groups, no sugar, no carbs, no dairy, being a vegetarian or vegan. Now, there are a lot of people that choose for many different reasons to be vegetarian or vegan, or to cut out dairy. Maybe they have an intolerance to it, or they don't like how they feel after they've eaten sugar or carbs. That is different than cutting it out completely in an attempt to control what is consumed and change their body, right? So it is different. And the difference, and sometimes it can be confusing, is the intention, right? Someone who is going vegan because they want to control their food and lose weight is different than someone who feels it is unethical to eat animals or animal products. Another sign is pretending to eat. So pretending to put food in their mouth and kind of pushing it around on their plate, or hiding it in a napkin, or dropping it on the floor for the dog to take away. Throwing away food or hiding food wrappers if eating excessively. So they might be throwing away food to hide it. They might be hiding the wrappers to hide that they've eaten a lot of food. Maybe wearing baggy clothes to avoid questions about their weight. Might be uncomfortable eating around other people where they can be seen eating. Might have some strong rituals, only eating particular foods like condiments, only eating ketchup and mustard. Having excessive chewing and sitting there counting. They take a bite and they chew it for 500 bites or chews, right? They don't allow their foods to touch. Now, this isn't always an indicator of an eating disorder. I had an uncle that didn't want any of his foods to touch. But it's typically we're going to see more than one of these things. So just one thing may not be an indication of an eating disorder, but we see a few things or something that's very extreme. You might notice some withdrawal from friends and activities, so they're isolating themselves. Might have some extreme concern about their body size and shape. Might be checking the mirror frequently, looking for flaws. Might also stop looking in the mirror and they're covering all of the mirrors with towels or sheets. Might be a lot of complaints about how they're looking. Might have a very intense fear about being or feeling fat or overweight. Might see some extreme highs and lows, so their mood is changing drastically. Really intense sadness, anxiety, or irritability, being prone to feelings of needing to be perfect, often feeling worthless. Then there's some physical signs. So fluctuations in weight, this would be both up and down, stomach cramps, chronic constipation, or other gastrointestinal complaints, pain, acid reflux. Might notice some menstrual irregularity, so missing periods or only having a period due to a hormonal contraceptive. Might be some abnormal lab findings, so anemia, low thyroid levels, low hormone levels, low potassium, low white and red blood cell counts. They might be feeling dizzy, especially upon standing. Might be complaints of feeling cold all the time if they've lost a lot of weight. You might see what looks kind of like webbing on the hands and the feet. This can be an indication of circulation issues due to being cold and can result in that kind of skin being patchy and irregular. So it's like a red and purple marks, maybe streaks, almost looks like a net on the hands and feet or maybe marbled. Disrupted sleep patterns, so they might have trouble falling asleep, staying asleep, or maybe they're sleeping too much. Might have some dental problems like enamel erosion, cavities, tooth sensitivity, discoloration, all from vomiting. Might be some cuts or calluses on the tops of their finger joints due to the inducing of vomiting. Might have some dry skin and hair, maybe some brittle nails. They might also have this soft, almost like I think we often call it like a peach fuzz all over their body. And this is a way of their body trying to protect itself from the weight it's lost and the inability to stay warm. So due to extreme thinness, there might be this, it's almost like a little fuzz all over the skin that is hair trying to keep the body warm. You're going to see a lack of proper nutrition that may be impacting the brain's ability to focus. The person might be feeling weak, have difficulty doing tasks due to weak muscles. Immune system might be impaired, resulting in frequent illnesses and potentially poor wound healing as well. Now, here are some signs specifically of binging. So, unexplained disappearance of large amounts of food in a short period of time. Lots of empty food packages, wrappers, often hidden at the bottom of the trash can or under the bed. Hoarding and hiding stashes of really high calorie foods, like what we would consider junk foods, sweets. There's a lot of secrecy, isolation, might eat an appropriate amount in front of others, only to then binge late at night or in private, where it won't be discovered or disturbed. All right, so how do we prevent all of that? Just as environmental factors can increase a person's susceptibility to an eating disorder, the opposite can be true. Changing the environment can facilitate prevention and it can facilitate recovery. For example, growing up with warm and nurturing parents could kind of mitigate the genes that predispose someone, or other environmental factors could help protect people from developing eating disorders. These things could be eating family meals, learning emotional regulation skills, and mindfulness techniques. And groups and individuals who question and challenge our unrealistic ideals of beauty And this is including, the glorification of thinness and the stigmatization of people that are overweight can also help and be protective. Many of these environmental changes, such as reducing the objectification of both men and women and increasing respect for people of all sizes and shapes, will benefit everyone. And these changes can help create kinder and safer and more protective communities. All right, so before we move on to talking about the specific types of eating disorders, let me check a few more questions. So someone asked if male and female children are affected by the mother or the female guardian's attitudes about food at the same rate. And for younger children, they are. As they get older, it's more, female to female, but it's interesting. Now, as you know, because young children typically, right, this is not for everyone, but typically their primary figure is female. And so just talking about themselves and how they view themselves in food, that's how they kind of take in those ideas and perceptions around body image and food. During teenage years, we do get affected more by someone of the same sex that we identify as, so that can be more impactful. Is it possible for someone to recover from having an eating disorder? And it absolutely is. Treatment is going to be important, participating in treatment, and sometimes, like with any kind of mental disorder, sometimes it takes a little while. Right? We go into treatment at different stages, and sometimes we're more ready than other times to start to make those changes and start to feel better. So someone asked, is it normal for someone to have kind of a restrictive diet, saying they're trying to be healthier and then binges on junk food and starts a diet again and binges on junk food? So they're asking if this is normal. It is typical. It does happen for a lot of people. And this may be not qualifying as an eating disorder, but more disordered eating, right? So an eating disorder is something, and we'll talk about it now, of how, it's a diagnosed mental disorder. We can have ways of eating that don't fit the diagnostic criteria for an actual mental illness, but it can be ways of eating that aren't healthy for us, such as restricting and then binging, but that also could qualify as an eating disorder. So if you have someone in your life that is doing this, you can offer them some support. Is it possible that someone who has become vegan also has an eating disorder? And that is not everyone that is vegan has an eating disorder. Not everyone with an eating disorder is vegan, but it is possible to have an eating disorder and as a way of controlling your food to choose to eat in a vegan type lifestyle. Just going through some of the questions. So someone asked, if you are overweight, so you go to the doctor, they indicate, that your body is just carrying too much weight for its size. You personally are recognizing some issues within your body. Maybe your knees are hurting, or there are different effects. Maybe you have high blood pressure or high cholesterol, and you choose to lose weight. This is not necessarily an eating disorder, right? This isn't about control. It's about wanting to be healthier. So that definitely can be two different things. So the desire to want to lose weight so you can be healthier, so you can be more active, have a stronger body, those are all valid reasons, right? And so we want to make sure we're doing it in a healthy way. And we're not reducing the calorie intake to a level that causes malnutrition or makes us sick or hurts our heart. And so, absolutely, if we want to either gain weight or lose weight for various health reasons, or because it would help us feel better about ourselves. That's okay. It's more about how we're doing it and why. Right. So a lot of about eating disorders is about that control piece. So let's talk a bit more about each eating disorder specifically, and that might help answer some of these questions about kind of that intent and why eating disorders occur and what they really look like. So we're going to go based on the DSM-5-TR. This is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition text revision. And so this is a manual created by the American Psychiatric Association. And in it, it lists out all of the identified mental disorders, information about each of them, including the diagnostic criteria. So this 5th edition came out last year, kind of around this time. So the DSM-5-TR lists several eating disorder diagnoses. We're going to focus on the 4 most common disorders. And so just for some information purpose, nervosa, so in the disorder anorexia nervosa or bulimia nervosa, in English, nervosa doesn't have a real definition, but in Latin, it means nervous. So kind of for contextual purposes, it means the psychological addiction to a behavior, a belief, or a habit that affects the body via the nervous system or the mind. So we'll talk about anorexia nervosa first. So in Greek, an means without, orexis means appetite. So people with anorexia starve themselves out of an intense fear of becoming fat or overweight. So despite being underweight or even emaciated, they never believe that they're thin enough. In addition to restricting calories, people with anorexia may also control their weight with exercise, diet pills. So there's that restriction of energy intake with that significantly low weight. And the disturbance in a way in which one's body weight or shape is experienced, right? So it's looking at oneself. Other people may identify the person as being very underweight again or emaciated. The person does not believe that they are thin enough still. So let's talk about these causes. Again, there's not one specific cause. There is a biological component. Those with a first degree relative, so a parent, sibling, child who has this disorder are at a higher risk, much higher risk of developing anorexia. It's not clear what specific gene, if there is even a specific gene that's involved, but there does seem to be some kind of genetic component. Some people may have, like we talked about, kind of a more genetic tendency towards things like perfectionism, sensitivity, perseverance, all traits associated with anorexia. Then we have a psychological component. Some people with anorexia may have obsessive compulsive personality traits that make it easier for them to stick to strict diets and forego food despite being hungry. They may have an extreme drive for perfectionism, which causes them to think they're never thin enough. They may have high levels of anxiety and engage in restrictive eating to try to reduce those symptoms. There's environmental factors. Modern Western culture really does emphasize thinness. Success and worth are often equated with being thin. Peer pressure may help fuel the desire to be thin, particularly among young girls. Dieting is a risk factor for developing an eating disorder. There's a strong evidence that many of the symptoms of anorexia are actually symptoms of starvation. Starvation affects the brain and influences mood changes, rigidity in thinking, anxiety, and reduction in appetite. Starvation and weight loss may change the way the brain works in vulnerable individuals, which may perpetuate restrictive eating behaviors and then make it difficult to return to those normal eating habits. And transitions make us at more risk, whether it's a new school, a new home, a new job, a relationship breaking up, the death of of a relative or a loved one, illness. These changes can bring about emotional stress and an increase of risk of anorexia. So what are the complications that come along with this? Anemia, so blood that doesn't have enough healthy red blood cells, fatigue, pale skin, shortness of breath, lightheadedness, dizziness, heart rate that's faster than normal, abnormal heart rhythms, heart failure, bone loss, risk of fractures, loss of muscle. And Females, there may not be menstruation, and males, decreased testosterone, constipation, bloating, nausea, low potassium, sodium or chloride, kidney problems, decreased urine output, fluid retention, swelling in legs, ankles, and feet, shortness of breath, fatigue, confusion, nausea, weakness, irregular heartbeat, chest pain, pressure, seizures, or even being in a coma in some severe cases. All right, so then let's move on to bulimia nervosa. In Greek, bulimia means ravenous hunger. So it involves a destructive cycle of binging and purging following an episode of out of control binge eating. People with bulimia then take drastic steps to purge themselves of those extra calories. In order to avoid gaining weight, they vomit, exercise to excess, fast, or takes laxatives. So we need to see for a diagnosis of this that reoccurrent episodes of binge eating. So an episode is characterized by eating in a discrete period of time. So within like a 2-hour period, an amount of food that is definitely larger than most people would be able to eat during a similar period of time and under similar circumstances. And then there needs to be a sense of lack of control over eating during this episode. So feeling like they can't stop eating or they can't control what or how much they're eating. We need to see reoccurrent, inappropriate, compensatory behavior. So the ways to lose that weight, induced vomiting, misuse of laxatives and diuretics, using other medications to get rid of those calories, fasting, excessive exercise. So both the binge eating and then these inappropriate compensatory behaviors need to occur on average at least once a week for 3 months. Self-evaluation is they're not really understanding their body shape and weight. So again, like in anorexia nervosa, they feel like they are bigger than they actually are, more overweight than they actually are. And then the disturbance does not occur excessively or exclusively during episodes of anorexia nervosa, right? So bulimia and anorexia need to happen separately. So what are the causes? Again, we don't know exactly. Girls and women are more likely to have bulimia than boys and men are. We're going to see it in late teens, early 20s most often. People with a first degree relative, again, like a parent, sibling, are at increased risk. Psychological and emotional problems like depression, anxiety, substance use disorders are closely linked to eating disorders like bulimia. And people with bulimia may feel negatively about themselves. Some cases, traumatic events and environmental stressors can be contributing factors. And again, dieting. People who diet are at a higher risk of developing an eating disorder. We may find in someone that has bulimia, negative self-esteem, problems with relationships, struggles with social functioning. They may be dehydrated. This can lead to kidney failure. Might be having some heart problems, severe tooth decay and gum disease from the vomiting, absent or irregular periods in females, digestive problems, misuse of alcohol or drugs to try to cope with some of the feelings that they're having, and self-injury, suicidal thoughts, or suicidal actions. Now let's talk about binge eating. Okay, so recurrent binge eating, so a large amount of food, a lack of control over what's being eaten. So they're really overeating, rapidly consuming thousands of calories in a short period of time. They will feel guilt and shame over this. Often they're going to binge in secret, but they really feel unable to control this. So we're going to see, this binging all of this food in a very short period of time, again, like 2 hours, and they're eating more than what someone typically could eat in that setting. They have lack of control over what they're eating. So that's very similar to that first piece of bulimia nervosa, but this lacks the purging. They aren't trying to get rid of the calories through vomiting, exercise, laxatives, or anything like that. So someone who is binge eating is going to be eating rapidly. They're feeling uncomfortably full, eating large amounts of food, even when they're not hungry. Eating alone due to the embarrassment. They feel disgusted with themselves, depressed, guilty afterwards. Often it occurs on average at least once a week for 3 months. And it's not happening at the same time as bulimia or anorexia. So it needs to be separate. And again, the difference between binge eating and bulimia is that there isn't those behaviors to try to get rid of the food that was eaten. So again, we don't know the exact cause. It's equally common in men and women. Often we're going to see it late teens, early 20s. Increased risk, again, if parent or sibling has an eating disorder. So it might be those inherited genes. We don't know exactly. Oftentimes, people with binge eating disorders feel negatively about themselves. Triggers can be stress, poor body self-image, and the availability of a preferred binge food. Oftentimes, feelings are what trigger that binging, difficult feelings that they're trying to cope with. And then people with a history of binge eating disorder also have a history of dieting. So dieting is linked to eating disorders. So someone with binge eating disorder may have a poor quality of life, problems functioning at work or school, in personal life and social situations, might be isolating themselves socially. Oftentimes they're experiencing obesity, and then the medical conditions that can come along with that: joint problems, heart disease, type 2 diabetes, GERD, some sleeping problems due to breathing disorders. And then lastly, we will talk about ARFID, avoidant restrictive food intake disorder. So this is an eating disturbance that leads to a failure to meet appropriate nutritional and energy needs. Does not involve any kind of distress about body shape or size or fears of being fat. And while picky eating and ARFID are similar, ARFID is differentiated by the level of physical and mental distress that eating causes. Right? So picky eating, I just don't really like this, I don't want to eat this. ARFID is causing mental distress. So it involves an apparent lack of interest in eating or in food. There might be avoidance of specific foods due to sensory characteristics or concerns about aversive consequences of eating, such as vomiting or choking. So there is the genetic component to this. Heredity can be a cause for eating disorder behaviors, cultural pressures to eat clean, pure, healthy, as well as increased interest in food processing, sourcing, packaging. Environmental impacts can impact the development of ARFID. Many people with ARFID also experience obsessive compulsive disorder. So in some extreme cases, obsessions with food intake and preparation can lead to kind of like a ritualistic compulsion. And anxiety can be another cause of ARFID, specifically in people who experience anxiety or fear around eating, that fear of choking, vomiting, dying while eating certain foods. So what are some complications? Cardiac complications, kidney and liver failure, bone density loss, anemia, electrolyte imbalances, low blood sugar, constipation, bloating. Person with ARFID who does not consume enough calories to grow and develop properly. And that's for children, right? So ARFID can be found in children. It's fairly common, more common in children than in adults. So we're going to see children that aren't growing, that aren't reaching their nutritional value. Adults, not getting enough nutrition to maintain basic body function. So in kids, we're going to see that stalled weight gain and stalled vertical growth. In adults, it may result in weight loss and then struggles meeting those nutritional requirements. So let's talk about treatment. So anyone who notices that they have a compulsion to eat large amounts of food or are restricting their intake of food need to see a doctor, even if you're at a healthy weight. So you're going to want to talk about things like your symptoms that you're experiencing. any kind of major stressors or life changes that have experienced, all the medications, vitamins, supplements you're on, and then bring a list of questions that you want to ask the doctor. You might also want to ask a family member or a friend to come with you. They may be noticing some signs and symptoms that you missed or have forgotten about. So you may be asked things like, how long have you been worried about your weight? Are you exercising? How much? Have you found other ways to lose weight? Are you having any physical symptoms? Have you ever vomited because you were uncomfortably full? Have others expressed concern about your weight? Do you think about food often? Do you ever eat in secret? Have any of your family members had symptoms of an eating disorder? So treatment approaches for each person really depends on their symptoms, the issues, the severity of these symptoms, in which disorder it is, right? So to be most effective, treatment for an eating disorder needs to address both the physical and psychological aspects of the problem. The goal is to treat any kind of medical or nutritional needs first. We want to get the body working appropriately before we start to address some of those mental health needs. So we want to stabilize the person. They may have to go into kind of a residential treatment or a hospitalization if they are dangerously malnourished and suffering medical complications. They'll be given nutritional coaching and counseling once they are physically more healthy, so they can understand how to design balanced meal plans. And then there's therapy, right? So therapy plays a crucial role in eating disorder treatment. Its goals are to identify the negative thoughts and feelings that are behind the disordered eating behaviors and to replace them with healthier and less distorted attitudes. Another important goal is to teach the person how to deal with the difficult emotions they're trying to cope with, the relationship problems, and then in stress in a more productive rather than self-destructive way. So, although there might be exceptions, eating disorder treatment generally addresses the following factors, typically in this order. So, we're going to treat any kind of physical health problems that are life-threatening. We're going to treat any psychiatric symptoms that are life-threatening, so someone that is suicidal. Then we want to interrupt eating disorder behaviors, so the food restriction, binging, purging. We want to establish normalized eating and nutritional rehabilitation, challenge unhelpful and unhealthy thoughts around food and body image. Then we want to address any kind of ongoing medical and mental health issues, and then establish a plan to prevent relapse. So lastly, let's talk about practical steps. So how do we talk to a loved one? We had lots of these questions in the Q&A. So first, we want to pick a good time, choose a time to speak to the person in private, where there aren't distractions. We want to do this when everyone's calm. We're not trying to have a conversation that's this important, maybe right after a blow up. Then we can explain why we're concerned. We don't want to lecture. We don't want to criticize. This is only going to cause our loved one to be defensive. We just want to refer to specific situations and behaviors that we've noticed and why it worries us. I have noticed, and I'm concerned because. The goal at this point is not to offer solutions, just to express concern about the person's health, show how much you love them and your desire to help. We can be prepared. They're going to be oftentimes denying and resistant. Sometimes they need some time to think about it, and that's okay. Don't take this personally. Let them know that you care and you're ready to talk when they are. If they're open to talking, but they're resistant to change, find out why. Find out what their reasons are. Then you can find out what reasons they have that they would want to change. They want to be able to go to school or work. They want to be able to run a marathon. Right? Find out why they would want to change. Then just be patient and supportive. Don't give up if the person shuts down at first. It can be hard to talk about, especially the first time. You want to listen without judgment. Tell them we're ready to talk when they are, and then just wait a little bit. What do we want to avoid doing? We want to avoid ultimatums. Unless you're dealing with an underage child, we cannot force them into treatment. The decision to change has to come from them. We want to avoid commenting on their appearance, telling them they've lost weight, telling them they've gained weight. Right? We don't want to reinforce any of the feelings that they're having. We don't want to use shaming and blaming. Avoid the you statements. You need to eat. You're hurting yourself, right? I find it hard to watch you struggling to focus due to brain fog. I'm scared when I hear you throwing up. We want to avoid giving simple solutions because this just isn't simple. All you have to do is accept yourself. Just go eat that one cookie. If it was that easy, they'd be doing it. We want to set positive examples. So we want to talk positively about ourselves. We want to eat in a healthy way. We're avoiding self-critical comments. We can make mealtime fun where we're, as a family, making food together, choosing it together, finding recipes together. We want to avoid struggles over food. We don't want to force someone to eat. This is just going to cause conflict and bad feelings. We can, require that they sit at the table, but they don't have to eat everything on their plate. We want to help trying to promote self-esteem within everyone in the household, right? We can do things that are intellectual, athletic, social, feel better about ourselves. And then don't blame yourself. If you have a loved one that has an eating disorder, it isn't your fault. Even if you are the parent, it is not your fault. Once you can accept that it isn't anyone's fault, we can kind of be freed to take action that feels honest and isn't clouded with the shoulds or the coulds. So, closing thought, recovering from an eating disorder takes time. There's no quick fix, so it's important to have patience and compassion, provide hope and encouragement, and stay positive through struggles and setbacks. Here are some resources for treatment, for support groups. We'll put all this information into that email we send out tomorrow so you have access to all of this. Same for these resources. So if you or someone you know are in crisis for an eating disorder or something else, right? These are different numbers you can call, text, message to get support, have someone to talk to, get more resources. All of the information on these 2 slides will be in that email we send out tomorrow. Now, May is Mental Health Awareness Month, and we're using this time to recognize friends and family who've been impacted by mental illness. Our goal is to connect people around the world to show that mental illness doesn't discriminate and that none of us are alone. So text Tribute 23, TRIBUTE 23 to 53555 to make a donation in honor, in celebration, in support, or in memory of that person. Add their name to our tribute wall. Use all the money that we've raised to create new webinars, reach more people, and make information more accessible. And at the end of May, everyone's tributes will be recognized through a piece of commissioned artwork. We're hoping to collect as many names and tributes as possible for this art project, and a donation of any amount helps us to continue to make an impact. Something else we're doing is the t-shirts. I got mine on right now. Check it out. So we've partnered with Raygun to create these cool new t-shirts. They're only $25, and part of the proceeds go back to MindSpring so we can continue creating resources and helping people to learn more about mental health. So I want to personally ask you to consider buying a shirt, not specifically because it helps MindSpring, but I think it really helps to normalize the conversation around mental health. And for me personally, as someone who has experienced depression throughout their life, and it felt so alone, especially when I was young, I think these shirts are so important. If I was young and had seen this on someone out in public, I would have felt so supported. So I encourage everyone to buy them and wear them and send pictures to us in your shirts so we can post it on our social media, share with your friends that these shirts are available, and they're only available in May. So make sure you hurry up because we're running out of May, which is just shocking that we're almost in June. I can't believe it. So we'll put the link to order these shirts in the Q&A. We already have a couple times. We'll also put in the email we send out tomorrow. Before we move on, let's do our first survey. My goal is for everyone to leave here feeling like you learned something. This survey lets us know if we reached that goal, and participation in this survey is required to be able to get that certificate of attendance. So that is on the screen now. While you work on that, I'm going to put up our upcoming webinars. Tomorrow is Wednesday, so we have 2, one in the morning during our time, and then in the afternoon again. So hopefully I see you twice tomorrow. And we'll put the link to register for these into the email we send out tomorrow. Also, here are ways you can contact us. Our website's looking good, mindspringhealth.org. You can send us an email at info@mindspringhealth.org. If you don't have social media and you want to send us a picture of you in your shirt that we can post on our social media, go ahead and send it to info@mindspringhealth.org. Send us an email with any questions as well. Or follow us on social media, Facebook, Instagram, TikTok, Twitter. We are everywhere at MindSpring Info. Give us a follow, share our posts. You can share our posts about our t-shirts that we've got posted now. Also, you can post a picture in your t-shirt and tag us so we can see it. I want to see everyone matching me so we can all be in our shirts together. And then let's go over our frequently asked questions one more time. This has been recorded, and everyone who registered for today's webinar will receive an email tomorrow with a link to the recording in it. Also, all of the resources we talked about today and the links, everything will be in that email tomorrow. No slides will be sent out. Certificates of attendance are sent to everyone who attends the live webinar presentation and completes both surveys at the end of the session. First survey is still up. You got about 5 seconds before that closes. Certificates are not available for anyone who's only watching the recorded version of the webinar later on. And CEUs are not provided for community education webinars. We have run out of time. Last thing to do is our demographic survey. A blue continue button will appear on your screen when you leave the webinar. Click the button to launch a demographic survey. It takes less than a minute to complete, and it helps us to continue these free programs. It's anonymous and confidential, and if you want or need that certificate of attendance, survey participation is required. Thanks so much for joining me today. It was nice to see you, and hopefully I see you twice tomorrow. Bye.